Hello, everybody. My name is Seven Song, and I am your teacher for this class about the penis, scrotum, testes, vas deferens, bulbourethral glands, seminal vesicles, and other related organs. So I want to talk a little bit about myself, and then I want to talk a little bit kind of the political side of this class, and then I'll just get into talking about the body parts, both the anatomy and physiology. So I hope you enjoy the program. You're going to, unfortunately, everybody's going to be on mute. It's easier for me. I get distracted rather easily. If you have questions, you could put them in the chat, but honestly, I'm not going to really answer any questions until the end. Again, I'm just one of those people gets thrown off course pretty easily. And so I like to just keep going forward as linear as possible for me, which is barely linear at all. So my name is Seven Song. I'm a Russian Jew, and I'm from Long Island, New York. Obviously, my grandparents came over from Russia in the early 1900s. And so that's a little bit about me. I live in Ithaca, New York, and I've been in Ithaca, New York for maybe 32 years or something. It's definitely my home. So there's a few things, I guess, to say about myself. First, I run a school. This is my 28th year running the Northeast School of Botanical Medicine. So I have a lot of experience teaching. I very much enjoy teaching. And I'm just getting to learn how to enjoy teaching online. I want to thank Michelle. So Michelle Marlowe is hosting this for me. And basically, Michelle helped hold my hands a couple of years ago when I started doing classes online to help me get more comfortable. So as always, thank you so much, Michelle. So I've been running an herb school for 28 years, upstate New York. I'm doing it again this year, but I'm going to take next year off. It's my 65th birthday year. And I want to explore more while my body is still functioning well. So I have no idea what I'm going to do. I'm not sure why you need to know that. But if you're interested in my school, definitely not next year, maybe 2024. But really, I think as many other people think, like, you reach a certain age and think, well, there's a lot I haven't done, and I'd like to get the opportunity to do it. So another thing that I've been very involved in is the Ithaca Free Clinic. The Ithaca Free Clinic is a multimodality or an integrated free clinic. And I'm one of the many founding members, and I've been there for 16 years. And it's been astronomically important to my practice as an herbalist. I only work 4 hours a week, but over 16 years, it adds up to many people. And so the free clinic, it's, we have doctors, massage therapists, chiropractors. It's all consultations are free. But also with the herbal medicine, we give herbal medicines for free if they're local. We don't send herbal medicines. And so the goal of that, of course, is because herbal medicine is often inaccessible because of the price. Also, people not understanding really how it's used. And if you follow the media and you look at what it says about herbal medicine, often it's very polarized, like herbs don't work, herbs cure COVID and cancer, right? And so, of course, plants have chemicals in them. And those chemicals can help facilitate health in our body. Sometimes they don't work. Sometimes they work great. Sometimes they work somewhere in the middle. So, herbal medicine is just one of many forms of medicine. And, so that's my specialty, but I feel really appreciative of working with people who do acupuncture, body work, and I'm working alongside nurse practitioners and doctors who have a whole other skill set. So I'm definitely, for me, being integrated is a very important part of my practice of being an herbalist. I think, though, what I'd like to focus on, so if you're interested in that, you can look up Ithaca Free Clinic, and then it's ithacahealth.org, but you'll find it pretty quickly, and you can see the work we're doing. I do consultations online. Again, we don't send medicines, but we do see people ever since the pandemic happened. We've, some of our practice, I still see people in person, but some of the practice has also moved online. But here's what I think the most important part of this program. Why am I doing a class on these body parts? Why am I doing a class on these body parts? The answer is really straightforward. So I started studying herbal medicine around 1981. And throughout the years of going to different schools and learning from different people, the one thing I found lacking was people talking about these body parts. Occasionally to be some talk about the prostate, which is important. But it was hard for me to get like some good factual information on how herbs interact with penises and testicles and prostates. So really for a lot of my adult life, it has been a focus of mine. More lately, I've been taking more to getting even more in depth in the anatomy and trying to figure out more how herbal medicine interacts with the anatomy. Anatomy is parts, and then physiology is function. So how herbal medicine interacts with the physical parts, like structure, and how herbal medicine interacts, with the physiology, and that would be like function, like ejaculation would be a function of these reproductive parts. And so, the focus has always been, and as it partly should be, about female physiology and anatomy, and I think that's extremely important. There's nothing to take away. The problem is just not having enough talking about the things that I have on my body. And so that's, part of the reason I'm teaching these classes now. I'd like people to understand about these body parts, whoever has them. And so I'm going to keep going forward. So as you notice, I keep saying these body parts. The reason for that is because these body parts show up on people who identify as male. These body parts show up on people who identify as female. And these body parts show up on people who don't identify as either. So in this class, I will sometimes use the word male as a shorthand, meaning inclusive for everybody who's interested in these body parts. But in no way am I trying to say that only males have these body parts. And if you're thinking I'm doing this because I'm politically correct or something like that, maybe I am. What I'm doing it is because a lot of people I know struggle with this, and I want to be somebody who supports people. And this is a very easy way to be supportive of people and how they perceive their bodies. Words that I won't be using in this class, and I just like to bring them up, are the gender construct words. So there's a difference between biological sex and gender. And most of the people here will know these, but I want to make sure that it's clear from the beginning. So terms like boy, girl, man, woman, masculine, and feminine, those are gender terms. Any of us could be that thing, right? So if I alter how I look and I alter maybe how I act and I dress, I could be identified easily as feminine or masculine. So that's a gender construct, and different parts of the world have different ideals and ideas on these gender constructs. Then there's the thing called biological sex or biologic sex, and that's the reproductive body parts that you're born with. This is also called often assigned at birth. So assigned at birth means that you have a vagina and a uterus, and you have obvious body parts that are often associated with female, or you have a penis and a scrotum, testicles, and that's often associated with male. But the person, as they grow and learn about their bodies, might not identify with those body parts. So I really want this to be open to everybody. I want this to feel comfortable as much as possible talking about body parts with everybody. I will use the word male occasionally in this class because I think it's just an easy term to use, though it is limiting, as words are. And I think that's it for that part. Don't worry, I will talk about it. It's not going to be a whole political rant day, but I think it's really important for us to start accepting people who have felt less accepted in the past. So next, I want to talk about sexual homology. So I'm not sure who here knows about sexual homology, but here we go. So when a sperm, this always sounds like the beginning of a fairy tale, maybe it is. When a sperm meets an egg, the first 6 or 7 weeks of development of that fetus is neither male nor female. So all of us, no matter what you are, right, no matter what you have down below, what you have up above, the first month or so of your life, first month and a half of your life during fertilization and the growing of the fetus, you are neither, right? Or yeah, go with it. You're neither. You can say you're kind of one more than the other. So what happens at about week 7 is if the sperm had a Y chromosome on it, then classic male reproductive structures will start to form. So this is very far away from what will happen then. But at about 7 weeks in, the Y chromosome has a special region on it that starts to convert the body parts to more male. If it doesn't have a Y chromosome, then it will always go towards female. So in other words, it all starts the same, and then about a month and a half in, it starts to change. And if the sperm had a Y chromosome on it, at 9 weeks, testosterone is going to start to be released and it's going to start circulating, and that's going to start to really make the changes that we identify as what are called primary sexual characteristics. Penis, scrotum, testicles, these are called primary. Secondary, what happens post-puberty. So like facial hair, for instance, is a secondary male characteristic because it's not initially formed at the development of the fetus. That's going to happen later in life when different hormones start to circulate at 9, 10, 11 years old. So why bring that up? Because I want to talk a little bit about sexual homology because I find it fascinating. Since we're all kind of started with the same blueprint, it's just alterations in the blueprint that happen later. So let me give you some examples. So homo, as in homology, homo means same. Sexual homology means the sexual characteristics on people are the same. Let's go for an obvious example. So the penis and the clitoris share very strong sexual homology. Spongy tissue that's very sensitive that can get filled with blood during excitement, right? So right away we have, so those two, and then we can go for many more. So another one would be the scrotum and the labia actually share a lot of sexual homology. They obviously look different because there's epithelial tissue on the scrotum, skin, which you don't see on the labia, but actually they share very similar characteristics. Probably the one that's the most interesting, or the one I find most interesting, is the similarity between the prostate and what's sometimes called the Skene's glands, or the female prostate. So when males ejaculate, fluid comes out of their urethra. When females ejaculate, so again, these are just shorthand terminologies for anybody who has these body parts. So if you have a vagina and you ejaculate during orgasm or ejaculation, similar fluid comes out. But here's the big difference, and this is going to show up in health of having male body parts versus female body parts. Males ejaculate through the same tube that they urinate through. This seems very obvious, but actually leads to a bunch of problems later on. Potentially, doesn't always have to lead into problems. Females, if you ejaculate during orgasm, like if fluid comes out, it actually is around the urethra. So in the female body, there's diffuse prostatic tissue. We'll talk about the prostate in a little while from now. But in the female body, there's diffuse prostatic tissue. And actually, some of the fluid that comes from that during female ejaculation is the same as a male ejaculation. And that's sometimes called the Skene's glands or the female prostate. It's very different because it's not one organ, it's diffuse tissue that releases fluid. So the point of all of this, right, is there's a lot of similarity. And I think often people focus on the differences between male and female. So I think that's really it for sexual homology. I want to cover a couple of definitions. So I hope I'm making sense. I hope people are following me so far. So there's 3 words that are really important in this class. There'll be many other words too. And hopefully my New York accent won't mangle them too badly. None of them have the letter R in them. So actually I'm pretty good with it. They are semen, there's semen, ejaculation, and orgasm. So I wanted to find these words because they're really important again. So semen is the fluid that comes out during during ejaculation. So ejaculation is the fluid that comes out during sexual excitement, and that's called semen. It's very commonly called cum with a U. It's often commonly called jizz. My guess is, please, you don't have to do this, but if we ask for chats and to everybody to put the different words for semen, there would be many, not as many as penis, but many different words. So mostly I'll call it semen. Sometimes I use the word cum just because it's such a very commonly used word for this. So semen is the fluid that comes out during ejaculation that usually has sperm in it. Ejaculation and orgasm, if you notice, I'm using the word ejaculation way more than I'm using the word orgasm. And the reason is they're two different things. So they often happen together, but they don't have to happen together, right? So ejaculation is fluid coming out of the penis during sexual arousal and then ejaculation. Orgasm is a sensation that follows with ejaculation. So not everybody who ejaculates has orgasm. So if you have a dysfunction of the pudendal nerve, there's one nerve that innervates. We go to Robin here for a second. There's one nerve that innervates many of these structures down in here. It's called the pudendal nerve. If that gets damaged during surgery or some other reason, actually, you might still ejaculate because that's on a different system, but you might not orgasm because the nerves have been disrupted. So once again, semen is the fluid that comes out. Ejaculate is the motion that makes the semen come out. And then orgasm often accompanies it, which brings the sensation of pleasure. So, and I think that's our basic terms. So another sip of tea. You would think after 28 years, I wouldn't get nervous at all teaching, but for those who do, I'm with you. It still takes a while to adjust. It's also just really exciting, and excitement and nervousness often intermingle in my body. So what I'm going to do at this point is I'm going to move towards this model of the penis and all the other parts and discuss them in some detail. And hopefully we finish in about an hour or so, a little bit more, so they have a good understanding how these body parts function. So first, we're going to start talking about the scrotum, all right? So in this model, this is the scrotum, and normally it would cover these things which are called the testicles. So we're going to start with the scrotum and then move to the testicles. So the scrotum is basically a sac that holds the testicles. It's a very physical structure. It's not hormonal. And it's made up of very loose skin. The reason for it to have loose skin is so it can contract or it can relax. So the main job of the scrotum is to hold the testicles outside of the abdominal cavity. The abdominal cavity would be here, and then the scrotum is outside of the abdominal cavity. Basically, abdominal cavity is like the insides of you. So the scrotum is considered on the outside of you. So the scrotum's job is basically as basically a testicle sac. There's many other words of saying testicle sac, but that's a common one. And so the scrotum has specialized muscles in it. And the muscles of the scrotum allow it to contract and bring it closer to the inside of the body, bring it closer up in between your legs, or to relax until the scrotum hangs further. Let's go over those muscles. So this is where the scrotum is removed, and these red lines are called the cremaster muscle. Cremaster muscle. It's quite a good word, really. Cremaster muscle. And then you can't see it, but inside of the scrotal tissue, so this is scrotum right here, and inside of here, it's not shown on this model, you have something called the dartos muscle. I'm not going to spell stuff. They're really easy words. None of these are things you'll find out in any kind of search. So the dartos muscle plus the cremaster muscle, their job is to basically relax when it's warm outside and contract when it's cold. And so why does that happen? This is a question that I have a lot of questions to. So physiologically, why this happens is because sperm does not grow in an environment. Sperm needs 1 degree cooler environment than the inside of our body. So again, sperm are formed in the testicles. I don't want to get too far into testicles yet because there's plenty to cover there. So sperm are formed in the testicles. And for whatever evolutionary reason, sperm won't mature unless it's 1 degree cooler. And so basically, in many ways, the testicles are like the fallen ovaries, right? So the ovaries and the testicles start in the same part. They develop different. They do have different functions, though they have similarities. Let me repeat that and be clearer. So the ovaries and the testicles start similarly. Both the ovaries and the testicles, or the testis, or the testi, or testicle, all those words are very similar. Some are plural, some are singular. Have a similar function, and that is to make the sex cell. So ovaries make eggs, testicles make sperm. The organs in a body, in a mammalian body, that make the sex cells, eggs and sperm, are called gonads. So the ovaries and the testicles are human gonads. The sperm from the testicles, the egg from the ovary. So here's the question though, why can't sperm mature at body temperature? I mean, if you can grow a baby, like that's a way more involved thing to do within the body cavity. I mean, it'd be really hard to grow a baby outside the body cavity, but that's a different imagery. So one point in evolution, who knows, 200 million years ago, when mammals started to come back, 60 million years ago, when mammals started to evolve, some reason, the testicles just descended, sperm started propagating in testicles, and then pretty much all mammals have it, where their testicles have to be outside of the abdominal cavity. So the scrotum's job is to try to keep the sperm safe and at the right body temperature. And you probably have seen it, right? If you go in warm weather, the testicles, the scrotum will just relax. Then if you're trying to run naked, it's kind of like it's like those, I forgot what you call them, those, like you throw one ball and then one ball comes up the other side, throw 2 balls and 2 balls come up the other side, whatever those are called. That's trying to run around naked in hot weather. So what we have is the testicles. We have the scrotum, holding the testicles. And then we have the testicles. So the testicles are the most complex part of today's class. The testicles have 2 main functions. All right. So first, there are 2 testicles in most people that were born assigned birth, male at birth. But sometimes only one descends. And so, but if you only have 1 testicle, the person will still be fertile. So for most people, the average, of course, is having 2 testicles. The job of the testicles, both of them, is to make testosterone and to mature sperm. So the only place in human bodies where sperm is produced are the testicles. But testosterone, which is called an androgen, testosterone is produced in 2 places in the human body. So testosterone is produced in the testicles, where the majority, if you have testicles, the majority of your testosterone will come from those testicles. If you don't have testicles, then the majority of the testosterone is going to come from the adrenal cortex. The adrenal gland is made up of 2 parts. The inner part, the medulla, that's where adrenaline comes from. And the outer part, the cortex, and that's going to make a number of hormones, including testosterone. So everybody's body has testosterone. The question really is how much testosterone, and that's really based whether you have testicles or not, because they're just going to make more testosterone. So the testicles descend at birth. Like what I was saying a little bit ago is that the ovaries and the testicles descend. And I want to show you on this model's name is Robin because it's androgynous. And I just love the name Robin. So I want to show you here. So here's the penis and the testicles, but actually the testicles are formed way up here. Excuse me a second, my line is caught. The testicles are formed right up over in here. And so the testicles will descend during fetal development, descend, descend, descend. Then they're going to push through the abdominal cavity, and then they'll be inside a scrotum. So it's interesting is the blood supply for the testicles is up here. Like here's one of the arteries for the testicle, and here's a vein for the testicle. Here's an artery, and this is a vein for a testicle. So it's interesting. So not the scrotum has a very different blood supply. But for the testicles, the blood comes from all the way up here down into the testicles. This is also where the nervous system comes from, the nerve tissue, and this is also where the lymphatics drain. So it's just interesting that everything that has a problem with the testicles can come up. If it's going to be in the blood, it's going to come all the way up in here where it drains. And also, this is where the lymph is going to drain. So this is just one more thing to learn about testicles. And so what happens sometimes in early child development is that the testicles don't descend. There's drugs to try to make them descend. Sometimes they descend on their own in puberty. There's some complications about that, but I won't go into that in this. But that's what they mean by undescended testicles, because often you think like they're just right down there, but actually they start pretty high up. So what more can I say about the testicles? A lot. So what we're going to do is I'm going to switch from me. I'm going to switch to a chart, and I want to talk about the inside of the test. Oh, I'm sorry. Before I do that, I want to talk about the outside of the testicle, and then we'll go into the inside. So do you see on this one over here that you don't really see the testicle much? This right here is called the spermatic cord. So the testicle, this is the testicle right here. This is a covering of the testicle. So when the testicle descends, it doesn't descend as a testicle. It descends like in this specialized sac, not the scrotum, but something called the spermatic cord. And so the testicle is going to descend inside this group called the spermatic cord. The spermatic cord carries all the arteries and veins and lymph and nerves that go to the testicles. So the scrotum is very different tissue. It drains differently, has a different blood supply. And the testicles, then the testicles. So it's just separating the scrotum from the testicles in this. All right. So we have the spermatic cord, we have the testicle, and I think that's enough about that. I get really dry throat talking to a computer. What I want to do now is we're going to go inside of the testicle. And here we go. So what we're looking now is inside a testicle. So inside of each individual testicle, so inside of each testicle, you have seminiferous tubules. Let's take those words apart. So a tubule is a small tube. Seminiferous means that it bears. Ferrous means to bear or carry something, as in the word Christopher. Seminiferous means to carry or bear, B-E-A-R, bear semen. The problem is they don't. So we're going to talk about the seminiferous tubules for a little while now, but important to know that semen, remember semen is the fluid that comes out during ejaculation. Semen, a very small portion of semen actually comes from this part of the body. So they were just named a long time ago before it's understood where semen mostly comes from, which we'll get to later. So there's about 800 seminiferous tubules in each testicle. So there's about 1,600 of these tiny coiled tubes in each testicle. So there's a lot of them in there. It's, so they're tiny and they're scrunch, scrunch, scrunch. If you actually took one out, they're microscopic, but if you took one out and stretched it, it's about 28 inches long. If you took out, so here's your weird visualization of the day. If you took out all the seminiferous tubules and you tied them together and you made a lasso, you can lasso somebody who's at the 400th floor of a building, right? So basically you get like 3,700 feet of this if you put them all together. So while you might not want the imagery of lassoing with your seminiferous tubules, what I find interesting is just like they're just so tightly packed. And why is that? Because once puberty reaches, all of these together are going to make 1,500 sperm a second. I think it comes out to something like 130 million sperm a day. We make, if you have testicles and if they're functioning, you make a lot of sperm every single day from puberty until death, unless something goes wrong with your testicle function. But this is also a very big difference between male bodies and female bodies, or people with penises and testicles and people with vaginas and ovaries. Really, it's the testicle and ovary that matter here. And that is males, once they start making sperm, unless they have a malfunction or something goes wrong, they make sperm for the rest of their life. There is no equivalent to menopause with males. So you could say there's an andropause when the body changes. And I would say that there are changes in male body and maybe other emotional changes that happen with males with age. But I think it's a bad comparison to compare it to menopause, which basically at one point, no more eggs are made. And there's a very big shift in the human body at that point. So the seminiferous tubules are where 100 sperm per second, about 130 million a day. I have the number somewhere, but you can just do the math. So it's a lot. Why so many sperm? Generally on ejaculation, it's somewhere between 60 to 200 million sperm per ejaculation. So we can go with an average, but there really is no average because there's lots of differences, but usually between 80 million and 100 million is a very common amount. So each ejaculation has up to 100 million sperm, right? And they're continuously produced. If you ejaculate frequently, you still make the same amount of sperm. The ejaculation doesn't change. If you ejaculate a lot, it could change how much fluid is in the vessels that we'll talk about. But the sperm production is just basically somewhat the same, though it does get lower with age. And there's been a steady decrease in sperm production through many different countries, the United States included, ever since the 1940s, a really significant change. So people who were in their 80s or 90s, when they were in their 20s and 30s, 40s, they would have probably ejaculated up to 120 million sperm. For many people, it's down to like 80 million sperm. There's lots of articles about it. Nobody's quite sure why. There's lots of guesses, pollutants, and as estrogens and who knows what, but it's pretty clear that it is. Will it be the end of fertility? Probably not, but often in infertility at this era, sometimes it's definitely the male not having enough sperm, because you have to have basically over 80 million sperm for pregnancy to take. So I'm going to move off from that subject. By the way, just to be extremely clear here, there are many things one can do with a penis, and it does not have to be intercourse with a female. So this class is open. I just want to say that, like, so often when people teach, when I've gone to classes on male, on this part, it's just like a penis goes in a vagina. A penis can go into an anus, a penis can go into a hand, a penis can go wherever it wants, where the person who has it, well, hopefully not wherever it wants. But what I'm trying to say is this is only one function of the penis, is for fertility and sexual intercourse with a male and a female, heterosexual intercourse. All right, that's a little bit more politic. So we have a lot of sperm being formed every second, and those sperm are going to be formed within these seminiferous tubules. The next picture I want to show you is going to be it's going to go even more in depth into the seminiferous tubules, so you can see what's going on there. So come back to me for a second, and then we're going to go here. So I hope I'm making sense. Hope I'm not talking too fast, but here we go. So this is inside a single seminiferous tubule. So remember, there's about 1,600 of these. If you actually lengthen them out, there would be 28 inches long, and there's just a gajillion sperm being made all the time in these things. So what we're looking now is inside of a seminiferous tubule. So there are two cells. They're going to show up later, and they're some of the most important cells within a testicle, within a seminiferous tubule. So this blue ring here is the perimeter of the seminiferous tubule. And then what you have inside of the seminiferous tubule are two kinds of cells. You have these cells here, kind of the smaller ones, they're kind of rectangularish. Those are spermatogonium. Spermatogonium are immature sperm cells. So when there's a lot of physiology here, but basically this blue layer is a germinal layer that constantly produces sperm. So, but the sperm that it produces is not ill-formed, it's not formed. And so the spermatogonium go through multiple changes in their development to eventually look like the ones in the middle, which are the common sperm that we recognize, the very tadpole-shaped sperm. So basically, they go from like an undifferentiated cell, the spermatogonium, and they go through a number of phases of meiosis and mitosis to eventually become the sperm. How do they get there? These cells, these bigger cells that are in the inside of the seminiferous tubules are called Sertoli cells. The job of the Sertoli cells are nurse cells. Their job is to bring sperm from its undifferentiated phase, when it just first separates from the germinal layer, when it first separates, becomes a potential. And then the Sertoli cell, through chemical interactions, is going to help mature it until it becomes a sperm. So basically, all seminiferous tubules have both of these things. They have a germinal membrane. That's the part that the sperm kind of come off of to start their process of becoming sperm. This is the part that the spermatogonium separate from continually throughout your life, and then eventually become sperm. And the job of the Sertoli cells is basically to move that process along. So that's the Sertoli cells. Outside and in between the seminiferous tubules, right? So there's 800 seminiferous tubules tightly packed inside there, inside each testicle. In between them are these cells, and they're called the Leydig cells. The Leydig cells make testosterone. There's plenty of Leydig cells also in the testicle, but they're not in the seminiferous tubule. They're in between the seminiferous tubules. We'll get more into testosterone later, but they're necessary for a few reasons. One of them is the Sertoli cells are dependent on testosterone to produce sperm or to mature the sperm. The Sertoli cells make a special protein called androgen binding protein to hold the testosterone that gets released locally by the Leydig cells to help with sperm formation. Testosterone, though, is also a classic endocrine hormone. So then testosterone is going to go into your bloodstream and read by the hypothalamus in your brain, which we'll get to at the end of this class. So we have the Sertoli cells inside the seminiferous tubules helping mature the sperm. We have the Leydig cells in between the seminiferous tubules, and their job is to make testosterone, which is going to help sperm formation, and then all the other many things that testosterone does in bodies. So I hope that makes sense. You see here, this is 200 microns, so it's very small. It'd be hard to see this. All right. So that's some of the physiology of the testicle. And so I'm going to bring back one more chart here, and that's this one. So what's going to happen here is that the sperm are going to be formed and matured in the seminiferous tubules. But even though they look like the little tadpoles that are destined to whatever destiny they have, the sperm are actually not mature until they mature for 2 months outside of the seminiferous tubules. I'll say this again. So if you took a seminiferous tubule and if you plucked the sperm out of it, it would look exactly like you would expect the sperm to look, but it is not functional yet. It needs a couple excuse me, it needs, I feel like I'm saying karma chameleon. It needs another couple of chemical exposures to alter its function so that it can swim, because it can't swim when it's in the seminiferous tubules. So what's going to happen is that the sperm are going to be formed in the seminiferous tubules, and then through a passive movement of fluid, there's fluid in there, and that passive movement of fluid, meaning the sperm are not swimming, they're being passively carried in a current of fluid, and then move from the seminiferous tubule up into the epididymis. So we're still in the scrotum, but now we're outside of the testicle for the first time. And this is called the epididymis. So here are some things you can do at home. Just I've mentioned, I just want to mention again now. We're going to talk about, you can feel you can feel your testicles, but there are two other body parts that are also, you can feel if you're interested. One of them is the spermatic cord. So here's the spermatic cord right here. And this is within the scrotum. The scrotum will occupy all this space. So if you want to feel your spermatic cord, it's actually pretty easy. So your testicle is kind of towards the base of the scrotum. If you kind of hold the testicle in place, so the best way to do this is when you are very warm and your scrotum is hanging down. So everything is very loosey-goosey in there. So if you hold your testicle, you don't have to hold it tight, just so it doesn't move around. And if you go above the testicle and kind of just pinch around it, you're going to feel this like tissuey sac in there. That's the spermatic cord. Don't press too hard, right? But it'll feel different. Like it feels like there's nothing there. You feel nothing. All of a sudden, oh, what's this? That's the spermatic cord. If you feel the top of your testicle, again, it's easier when you're relaxed and you hold the testicle. And then if you feel towards the top of it, you will feel a bump on the top of your testicle and a little bit towards the back of it. And that's the epididymis, which is, it takes a little time, but it's pretty easy to feel once you're looking for it. This is the epididymis here. Again, it's a feelable thing. It tends to be, though, very sensitive. So like when you put pressure on the epididymis, often there's a sensitivity or even pain from it. But, so you do it gently to feel the epididymis. Why would one do this? Here's the answer. An important thing, so often people with breast tissue or more breast tissue are taught to do breast self-examination because breasts can get lumps and they can also get cancerous. The testicles also can get cancer. So this is not a very positive, but this is a very true thing. And one of the most common forms of cancer in people with testicles between the ages of 15 and 35 is testicular cancer. So it's not that common a cancer, but in that age group, it exists. And so one thing that's an advantage of having your testicles outside of your body is you can feel them. So one way to do it, sometimes people say warm, soapy water, but actually it's pretty easy to feel. So basically, what you do is you're going to hold your scrotum, and then you feel you hold one sac aside, and you kind of feel your testicle, and you can feel around it. But you will feel your epididymis, which will feel like a bump on your testicle. So you want to make sure you don't get nervous about feeling that bump. One thing is, if you know how both your testicles feel, they should be pretty similar in their structure. So this is called a TSE, a testicular self-examination. It's helpful. I also think it just breaks taboos from people for touching themselves for other reasons, right? So there's sexual enjoyment reasons to touch oneself, meaning your genitalia. And then there's also this very physical thing of checking yourself for testicular cancer or for any other weird lumps and bumps. Other things can happen. While saying other things can happen, I want to point out that this class today is really just anatomy and physiology. And next Tuesday at 6:30, if you can bear my voice anymore, I'll be doing a class on male health issues or health issues associated with these body parts, and mostly focusing on the prostate, for the first one at least, because the prostate is just one of the most common health issues, that and erectile dysfunction that I see in practice. And that some herbs can sometimes help, especially the prostate problems. Another sip of tea. All right. So what have we covered so far? We've covered that the scrotum contains the testicles, and the job of the scrotum is to move the testicles either closer inside the body when it's cold or to hang loose when it's warm. Inside of it, when they have two muscles that do that, the cremaster, which is this one right here, and the dartos, which is in the lining here. Then we have the testicles, which are the most physiologically complicated of the body parts we'll discuss today. Inside of the testicle, it's divided into lobules, sections, and they contain, each testicle has about 800 seminiferous tubules. Inside the seminiferous tubules is where sperm is made. It is the only place that sperm is made in the human body, in any human body. And then in between the seminiferous tubules, you have Leydig cells, and they make testosterone. So the testes create sperm and mature sperm, and then testosterone helps the maturation of sperm and also has many other functions in the human body, because not only is it used locally by the Sertoli cells, but it's also goes through the bloodstream, and whatever has a testosterone receptor, that's the thing that'll be affected by testosterone. So next, so here we're going to take a little, I'm going to take the penis off here. And we take a little journey. So as we've learned, the Sertoli cells inside, or excuse me, the seminiferous tubules inside the testes, that's going to make the sperm. The sperm are going to move passively, kind of if you threw a stick in water, if you threw 1,500 sticks in water every second, more like that, and it'd be very, very, very tiny sticks. It's going to move from here inside, and it's going to go up here to the epididymis. And then it's going from the epididymis to this tube right here. It's this yellowish tube right there. So basically, the epididymis is continuous with this next tube. That tube is called the vas deferens or the ductus deferens. I'm going to say that again, the vas deferens and the ductus deferens. I'm just going to call it the vas deferens because it's easier just to call it one thing. But as you can imagine, what we have now is that the sperm have moved from inside the seminiferous tubules into the top of the epididymis. They're going to travel down the epididymis, and then they're going to go and they're going to follow. I'm still learning how to use models online. They're going to go up the vas deferens. They're going to spend about 60 to 70 days. Each little sperm is going to spend a month or a little more than a month in the vas deferens and epididymis. And the reason for that is they're going to be altered so that they become fertile sperm. Once again, if you took a sperm out of a seminiferous tubule, it would look good, but it would be infertile. The fertilization property, really the ability for it to flagellate or move, takes a couple of weeks post formation in the seminiferous tubules. It happens in here in the vas deferens. So testicle, seminiferous tubules on the inside of it, epididymis, then into this vas deferens. And for the first time now, the vas deferens is going to go inside the body, inside the abdominal cavity. Everything I've discussed so far is in the scrotum, which is outside of the abdominal cavity. It's going to go inside for the first time. So let's talk about something I forgot to mention previously. So how do the testicles actually get through here and kind of emerge outside of the body into the scrotum out here, right? Because they're inside the abdominal cavity. How do they get through? The answer is there's a special area in that region called the inguinal canal. You might know the inguinal canal because it's a place that sometimes herniations happen. It's where muscle or intestine can push through. So what happens is as the testicles descend, so I'm sorry I'm bringing it back a couple of paces, but as the testicles descend, they start to push through the abdominal wall and kind of carry the scrotum with it and push through the scrotum and then the testicles on the outside. And they go through a specialized region called the inguinal. This whole region here is kind of the inguinal region, like you have inguinal lymph nodes and such. And that's going to push it through. It's also going to leave a little bit of a weakness, right? Because there's tubes going down through that area that if you have testicles, that area is a little bit more, you just have less muscle mass there. And so occasionally muscle can move down into the scrotum or even intestinal tissue. And then there's different degrees of what that is. Sometimes it's fine on its own, it goes away, and sometimes it needs help. You can learn about inguinal hernias, but that's what they're called. All right, so the vas deferens then is going to go back up through this inguinal canal, and then we're going to trace its length. But before we do this, here's where it's an easy way to remember that it's called the vas deferens, and that is a vasectomy. So a vasectomy is a snipping of the vas deferens in the scrotum. So there's two of them, right? So everything here is bilateral, both sides. And you have vas deferens. You can't see it on this model because you have the spermatic cord. But you have vas deferens. And what a vasectomy is basically they're going to make an incision, a really very small incision in the scrotum. They're going to cut the vas deferens, and then they're going to seal them. There's numerous ways. There's cauterization, there's sewing method. There's a lot of different ways that vasectomies are performed. And you can look them up. There's probably like 5 common ways, but they all do exactly the same thing. They cut the vas deferens in the scrotum, and then they seal the ends up. If you don't seal the ends up, the sperm can still make it from one side to another. Many years ago, I had a student in my program that was a vasectomy child, and they're pretty uncommon, frankly. They're usually very successful as far as stopping pregnancies. So while I'm talking about vasectomies, I just want to point out something I think is very important. And that is, so vasectomy reversals often don't work. So it's about a 50% time, that's like half the time, the reversal, meaning, so you had a vasectomy for all the right reasons, and now you want to have intercourse with somebody, you want to have a baby with somebody, to make it really simple here, language-wise. And so you have a vasectomy reversal. Unfortunately, there's a number of reasons that vasectomy reversals don't take. So if you're thinking of vasectomy, and there's great reasons to have vasectomies, mostly for infertility, right? For stopping pregnancy, really, not for stopping pregnancy. Often it's important to, and doctors will discuss this with you, is getting your sperm frozen. Because if the reversal doesn't take, so if you, all right, this is a very individual choice. I'm going way too into it, but I just think it's really important to know about vasectomy reversals. They're also really more expensive than vasectomies, which seems weird and true. So what's going to happen now is we're going to take this model apart. So we have sperm formed in the testicle, in the seminiferous tubules, into the epididymis, through the vas deferens. It spends about a month or more in this area, becoming fertile and being able to wag its little tail. It's called a tail. And then it's going to move in. And so we're going to try to follow its path here. So what's going to happen is the vas deferens, that's this thing here, is going to come up, it's going to go into the body cavity, and it's going to, excuse me a second, which is the better way of sewing? It's going to, all right, sorry. Let me get this really good here. The vas deferens is going to go into the body cavity. It's going to circle around the bladder. Sorry, I haven't mentioned that yet. I don't really have to be right there, do I? And then it's going to attach to the prostate. I'm going to open this up in a minute, but let me do it. Before I do it, excuse me, I'm still learning how to do this class well. Let me point out 2 important non-reproductive structures that come into play a lot for male health or this kind of body health. And they are the bladder, which is this thing, and the rectum, which is this thing. So the rectum is the end of the large intestine, and it's where you store poop. Right here's the anus. The anus is where you release poop. So we're going to talk about it because constipation and prostate problems can be associated. One more thing I haven't talked about, so apologies again. I keep going. So here's the bladder. That's where urine stores. Here's the rectum. This is where feces is stored. Here's the anus. This is where feces is released. And then this right here, this band of muscle is called the pelvic floor. And actually a lot of health issues happen when this muscle, which holds like everything below your diaphragm kind of in place, gets loose. So I'm not going to do a class on the pelvic floor, but I find learning about it really helps me understand a lot of other issues that have to do with problems with fecal incontinence and urinary incontinence and with erectile problems. Right. So the reason I'm saying all of that is what we're having here is that the vas deferens is going to go into the inguinal gland. It's going to come around. It's going to circle around the bladder. Let's take this apart. It's going to circle around. It's going to come up. Here's half of the, so this is the model I'm looking at now. And let me put on a piece of the penis. I think it'll make more sense. Where does the penis go? I'm feeling really embarrassed at the moment. Right here. Half. I'm probably making some crazy looking faces because I'm having a hard time getting this in this hole. There we go. So sorry for the interruption there myself. So the vas deferens is going to come around and it's going to circle around the bladder. So here's the vas deferens. The vas deferens initially was down here. So here's the testicle, maybe about here. The vas deferens is going to come up, go into the body cavity. Then it's going to circle around the bladder. This tube right here, that's the ureter. That's what urine is coming from the kidneys up above. So the kidneys up here, and urine's going to come down and come to the ureter, which is here, and empty into the bladder. They're really not a part of the discussion. The only thing is you're going to see that because the vas deferens is going to kind of circle around on top of the ureter. The vas deferens is going to go all the way around, and then it's going to end here on the end of the prostate. So the vas deferens is this. Remember, this is coming all the way down from the testicle. It comes up into the body cavity. It's kind of long. It's going to circle around the bladder, and it's going to end right there. And then it's going to release its contents into the urethra. So before I go further, we have to talk about the urethra because that's where a lot of the action is going to happen from this point on. Here we go, more body parts. So again, everybody, can you name this? You don't write it, just what is this? This is the rectum. That's where feces is held. What is this? That's the bladder. That's where urine is stored. And then what we have here is we have this tube going from here, from the bladder, out to the tip of the penis. That tube is called the urethra. And it, especially with next week's class, it's going to come into big play here. But it's also just really important. Remember, like I said in the very beginning, one of the big differences between people who have vaginas and people who have penises is where they ejaculate. And so if you have a penis, you ejaculate through your penis. If you don't, if you have a vagina and the other body parts, you're going to ejaculate through the Skene's gland and not through the urethra. Some fluid can come out the urethra during female orgasm, or just uterine orgasm, vaginal orgasm, excuse me. But in males, you're gonna pee and come out of the same tube. So that's the important part here. So we have the bladder, then we have the urethra going from the bladder through this organ and all the way out to the tip. So we have, that would label them. So again, rectum, bladder, and then now we have the prostate. We're going to spend some time in the prostate, but the important thing here is that the urethra, the part that urine goes from the bladder to the end of the penis, is right underneath there. And an important thing to notice how tight that prostate is and has almost no room to really expand, which causes a lot of problems. So the prostate is here and it's right up against the rectum, it's right up against the bladder. And so it has very little maneuverability, which means if the prostate swells, it usually swells inward, which is its own problem. So I want to point out that you can feel your prostate. So I know I'm giving a bunch of feely exercises here because why not? So if you notice though, the prostate is right up here against the rectum. If this is how doctors or medical professionals check for prostate cancer, only a little bit of it can be checked this way. But you can, if you put your finger and into your rectum and point it this way, you can easily feel your prostate. And so if you have prostate cancer, there might be lumps there. That's what they're checking for. I think we'll talk more about that in the next class. But I'm saying if this is a class you take, it's good to trim your fingernails and lube up your finger. It depends how loose you are. But it's easy to feel it. And the prostate is an erogenous organ. I mean, it has sexual sensitivity. So any kind of anal sex could stimulate the prostate. All right, so where do we go from there? We're going to go from there is we're going to get back to the vas deferens. So here's the bladder and here's the prostate taken out. This is just a peg that holds it in. So the vas deferens comes around the bladder, and then it's going to attach here on the top of the prostate. And then we have these tubes right here, and they are the seminal vesicles. So next, seminal vesicles. Say that with me. Seminal vesicles. They are not, and say this with me, the seminiferous tubules. So the seminiferous tubules are in the testes. The seminal vesicles are up here, pressed against the bladder. And they're going to meet with the vas deferens, and they're going to make fluid that's going to go into the urethra, which we'll get to in a second. So what do the seminal vesicles do? They contribute about 2/3 of semen. So they actually are correctly named seminal vesicle. Vesicle, small vessel, seminal, making semen. So the seminal vesicles, these things right here, these tubules, that's where a majority of semen is made and released during ejaculation. So of course they have, not of course, sorry about the of courses. So they're a bit muscular because ejaculation, as we'll talk to later, has to have contraction to push semen with sperm into the next area. So there's some muscles on all of these things, the vas deferens, the seminal vesicles, the prostate in a different way. They also have muscles in them. They have connective tissue that's able to contract during ejaculation to move, to propel the semen with the sperm through and out. So the vas deferens coming from here, that's going to carry a little bit of fluid, up to 10%, but mostly it has the sperm. It's the only place where sperm is going to come from. And that's going to come out during ejaculation. And then right here, we have the seminal vesicles. The seminal vesicles are where a majority of the semen come from. I want to point out also that the numbers are not going to all add up because they don't, because not everybody has 70 or 30 or 20 or 10 or anything here. But they're basically good averages. And then what they're going to do is that during ejaculation, there's going to be fluid from the seminal vesicles and the vas deferens, and you can't see it here, but there's a duct, a tube that goes from here into the urethra that's going to carry the fluid from the seminal vesicle and the vas deferens, and it's going to be called the ejaculatory duct. There are two of them. There's one on each side because this is all bilateral. And so during ejaculation, I'm sorry this model doesn't have this. During ejaculation, this is going to contract and release a little bit of fluid with sperm, and that's the vas deferens. This is going to contract. This is the seminal vesicles, and they're going to contract and put fluid into the urethra. And that's part of semen. That's a big part of semen, and that's going to be a part of ejaculation. So hopefully people are following. Next, the prostate, the organ that's so swell and can swell so much. I didn't mean to do a pun right there, but I'm definitely old enough to have dad jokes. So this is the prostate gland. And the job of the prostate gland is actually very similar with slightly different function than the job of the seminal vesicle. So the prostate gland makes about 25% of the semen. So between the seminal vesicle and the prostate gland, the majority of semen is formed. So what is in semen, right? So semen is the fluid that protects and nourishes and energizes sperm. So sperm is coming from the testicles up through the vas deferens, and now it's going to come and ejaculate. And when the sperm comes out, it's going to be put into this alkaline, milky fluid that's going to protect the sperm, or that's one goal of it. Why does it need protection? Because sperm cannot live in an acid environment. Sperm live in an alkaline environment. And so all of these, this fluid and there's one more fluid to come, all of them alkalize the urethra. So that what they're going to do is, because urine is acidic, right? So the urethra, this fluid, this term here, tends to run acidic, right? So you're going to have acidity in here. So one of the jobs of the semen, not sperm, is to surround the sperm and give it a more hospitable environment for it to survive. The semen has other stuff in it. I'll name some of them. It has prostaglandins. Prostaglandins, which are found throughout the human body and create inflammation, were named for initially being discovered in the prostate. That's why they're called prostaglandins. Nobody's quite sure why they are, but one idea, it's one I think is interesting, is that so the semen has prostaglandins and it causes the vaginal walls to very slightly modulate, which makes enough movement for sperm to possibly go into the os, into the cervix, and into the uterus. So, but nobody's quite sure why prostaglandins are there. Other things that are in there are alkalizing fluids. There's also fructose and other sugars. So there's citric acid, vitamin C, and there's fructose also in semen. That's to give the small cells, the sperm, energy. There's also a lot of zinc. Nobody's quite sure of the reason for that, but the prostate uses more zinc than any other part of a body with a prostate. So zinc supplements are a little bit controversial. I'm not suggesting them at this point because of different studies, but zinc sometimes is really helpful for prostate problems, but it's important to read more about it before taking especially high doses of zinc. So during ejaculation, we basically have the movement of sperm and fluid from the vas deferens. We have semen, fructose, vitamin C, alkalizing prostaglandins coming from the seminal vesicles. They're going to go through an ejaculatory duct. That's going to go into the urethra. The prostate is also going to contract and add about 30%. It has slightly different chemical composition than seminal vesicles, but I think for this class, it's not so important. And then one more stop along the way before it goes to the outside world. So right now, we're talking about ejaculation. We're talking about the contents, the vas deferens with sperm, the seminal vesicle, and the prostate. And there'll be one more small package of fluid coming out. And one of these shows it better than the other. Excuse me a second here. One of these needs glasses. Let's see if I can find this. Perfect. All right. So right here, all right. So I keep not mentioning the penis. This is the penis. So rectum, bladder, prostate, we saw these other parts, the urethra, and right here, right above my fingernail, this little gland right there, that's called the bulbourethral gland. Say that with me, bulbourethral gland. It's sometimes called the Cowper's gland, and in female bodies, it's called the Bartholin's gland. It's actually a little bit more known in female bodies because you get cysts. You can get Bartholin's gland cysts. They're much more noticeable because they're in labial folds or vaginal folds, whereas the bulbourethral gland is not something you would ever feel. It's way up there inside the penis. So this little organ there contributes what most people call pre-cum or pre-ejaculate. So as somebody with these body parts is going to have an ejaculation, before they ejaculate, before that orgasm happens, a little drop of fluid comes out the tip of the penis. That fluid is coming from the bulbourethral gland, that little gland, and its job, as we can think about it, as nobody's really quite sure, is again to neutralize the acidic environment inside the penile urethra. I know there's a lot of words coming at you today. Penile urethra, something you can use tonight at a party. So which one was this? So before ejaculation, remember ejaculation is just slightly different than orgasm. Orgasm often accompanies it. Before that, this little gland there is going to do a little squeezy bit, and it's basically going to put an alkaline fluid that's going to go through the penis so that the urethra, this is the urethra inside the penis, so the inside of the penis is more alkaline and less acidic. Pre-cum, the fluid that comes out of it, pre-ejaculatory fluid, doesn't have sperm in it, but it could have STIs. So as far as having unprotected sex, that's one thing to consider. The other thing is the person's about to ejaculate, right? I mean, this is kind of the point of no return. Like that person, like unless they plug it up, and don't plug it up, you're just going to ejaculate. But before ejaculation happens, there's a little bit of pre-cum. So that's a lot of the physiology. So we still have, of course, one more organ to cover, and that's the penis. So I'm hoping that everybody gets this so far, what I've covered. And I'm going to talk a little bit about the penis. And I'm going to see if I can find a little hole in here to stick the prostate back on. Talk about it. Hope I'm not making too many weird faces while doing this. If only he would wear his glasses more often. Someday. There we go. So next is the penis. The penis is also not a hormonal organ. Really, the only hormonal organ I've talked about today is the testicles. But it doesn't mean it's not sensitive. It just means it doesn't make hormones. It has its own distinctive odor and other aspects to it. All right, here we go. All right, model back together. Should be able to name the parts. Let's do it. You just do it in your own mind. What is this? That's right, it's the rectum. What is this group of muscles there? The pelvic floor. What is this over here? This is the bladder. The bladder is, so this part has the perineum, and this part, you just see the muscles. That's why they look different. What else do we have? And then, yeah, we'll go to the penis. So here's a penis. This penis doesn't have an opening, which is would be a very, very big problem in a human being. But this is the tip. This is a circumcised penis. Mostly penises have foreskin on them. The people are born with foreskin. That's a whole other issue to remove foreskin or not. I'm not going to move into the politics of that. So this is the shaft of the penis. And then this is the head of the penis. And this would normally be covered with foreskin, which helps protect the tip of the penis and other sensitive parts in there. So what about the penis? What about the penis? I should never have seen that video called What About the Spleen? Something about the spleen. It was a long time ago. So the penis, first, a lot of the penis is in the inside of the body, or a small portion of it is. I took a great class with Gil Headley. Gil Headley does dissections, and probably 15, 20 years ago already. And I did a dissection lab with Gil. So it's a dissection lab for people who don't go to colleges or something that have dissection labs. That was amazing. It was 7 days of slowly opening up cadavers, really so useful. And one of the things I've always wanted to see is what's called the root of the penis. And if you look at this model here, this is the root of the penis. This part of the penis is inside of the body cavity, and then this part of the penis on the outside of the body cavity. I just really always wanted to see one live. So, dead, I guess. Bad jokes, Evan. So, then if we look at the penis, we're going to see that it's made up of basically two kinds of spongy tissue. We have what's called the corpus. Corpus means body. The corpus cavernosum, say that with me, corpus cavernosum, like cave. And that's this spongy tissue here. There's two sides of it, each on each side of the penis. And then we have the corpus spongiosum. And the corpus spongiosum surrounds the urethra. So again, if we bring this in closer, this tan part right here, that's the urethra. It's surrounded by a specialized spongy tissue, which you can see a little, you can't see it that well here. And so the penis is basically, epithelial tissue, with spongy tissue inside, with specialized blood vessels. And then it has everything else. It has lymph system and nerve tissue, like just the normal stuff you would find inside any body organ. But its specialty is spongy tissue and the way that it functions. And so basically the penis has 3 layers of spongy tissue, 2 of them called the corpus cavernosum, one of them called the corpus spongiosum. And let's talk about erection. So what is erection? So first, erection comes in many forms, right? So erection can be non-erect, flaccid, so that's not an erection, but you can be like half-mast or full-mast. You can have a full erection, like your penis is just filled with blood and you're as erect as you're gonna be. You could be like partially erect, where you're kind of stiff, but not fully erect. So there's really kind of a continuum of how erect somebody is, as opposed to it's either erect, flaccid, non-erect, flaccid to erect. So what causes an erection? An erection is caused by parasympathetic innervation to the blood vessels in the penis. I'll say that again. So erection is parasympathetic innervation. So what does that mean? So you have 2 parts to your nervous system, and both of these are going to be important because ejaculation is very different than erection on how they function. So erection is governed by the parasympathetic nervous system. That's the part of the nervous system that many people call rest and digest. So the parasympathetic nervous system, coming from somewhere around here in the spinal area, is going to send signals to the blood vessels in the penis to relax. When the blood vessels in the penis relax, blood is going to flow into the spongy tissue, which have valves, so the blood doesn't just flow out. So the blood vessels is mostly this one right here. You can see it on this one right here. So the helicine arteries right here. So these are major blood vessels. There's blood vessels throughout. And this blood vessel is going to relax, and it's going to fill this corpus cavernosum, or the spongy tissue, with blood. And as long as there's sexual excitement going on, the blood is going to keep, those blood vessels are relaxed, and blood is going to keep moving in to the spongy tissue, and the valves are going to stop it so it just doesn't go right back out of the spongy tissue and right back out into the veins, and that would lose the erection. So erection is a function of the parasympathetic nervous system that relaxes blood vessels. So what I want to do here is I want to spend a few minutes and discuss, get into a little more detail, because it's going to tell you how erectile dysfunction drugs work. They all work the same way. They're slightly different modifications of each other. So this is a little more complicated, but here we go. So when the parasympathetic nervous, so when you're under sexual stimulation, whatever that is for you, when you're under sexual stimulation, your parasympathetic nervous system is going to cause the blood vessels in the penis to release nitric, not nitrous, laughing gas, nitric oxide. Nitric oxide is an amazing gaseous hormone. So what's going to happen is through parasympathetic innervation. Innervation just means it's turning a switch on. Through parasympathetic, so you're stimulated, you're at the bottom of your spine feeling that, and it's going to send the signal to your penis, and it's going to send chemical messengers. What the first chemical messenger is going to be nitric oxide. That's going to cause something called GMP or CGMP to then dilate the blood vessels so that blood flows in. The reason I'm giving these specific terms is because I want to discuss how the erectile dysfunction medicines work. So we have is nitric oxide interacting or innervating CGMP, and you can look up what that is. And then the CGMP is going to relax the blood vessels. And while that's happening, blood is going into your penis and causing erection. At the same time, there's a local enzyme called phosphodiesterase 5. Phosphodiesterase 5. Anything that ends with ASE is an enzyme. So phosphodiesterase 5, abbreviation is PDE5.
The job of PDE5 is to break down the CGMP and stop the erection, right? The reason for that is because otherwise erections would last way too long, right? So erections can be fun, exhilarating, whatever you want to say about erections, but to have them all the time can be kind of difficult. So our body has a system to reduce the erections. So what happens is while you're still stimulated, the PDE5 is just not strong enough to stop the CGMP from causing blood vessel dilation, causing erection. So basically the enzyme doesn't have enough, it's not strong enough, it can't counter the effects that are causing erection. So what happens as sexual stimulation stops or gets reduced, the PDE5 becomes more dominant and then the erection goes away. So erectile dysfunction is a term meaning that you don't have an erection long enough for you or someone else's pleasure, right? So mostly it's you, right? I mean, it's your penis, your erection. But of course, you know, erectile function matters. So I'm not going to spend a lot of time talking about erectile function. That will happen in the next class. I just want to talk about PDE5 because I think it puts the whole thing in perspective of erections. So there are three main drugs, and there's a bunch of knockoff drugs these days. I'm getting ads for, I mean, I'm 64, so I'm getting all these new ads for something they call the little blue pill. Anyway, Cialis, Viagra, and Levitra are three drugs that help maintain erections. Notice I'm saying they maintain erections, they don't give erections, because and they don't directly give erections. I'll go into this in a minute. What all three of those drugs do, Cialis, Viagra, and Levitra, what they do is they're PDE5 inhibitors. They interfere with the enzyme that interferes with the thing, CGMP, that's causing erections. So the PDE5 inhibitors, basically, once you have an erection, they inhibit the enzyme that reduces the erection. So all of those drugs do exactly the same thing, and actually fairly safely. I'm pro erectile dysfunction drugs because I don't know herbs that do it as well as those. So we can talk about pharmaceuticals at another time. But the point is, I think it's just really interesting. In case you're curious, excuse me, the PDE5 inhibitors were initially used for heart disease. And so they were being tested, they were in clinical trials for heart disease, and then males who were taking them, people with penises, were noticing that they had longer erections. Well, not the penis didn't get longer, but they're longer lasting erections. And then you can just imagine the drug companies are like, what the heck with heart disease? We got the drug that will make us more money than any other drug. And they were right. That's the Viagra, the first people to do the PDE5 inhibitors. Those things made massive money. They still do, though. There's a lot of generic versions at this point, or there's some generic versions. So I hope that made sense. So basically, the penis is an organ with spongy tissue. When blood vessels relax in the penis, the spongy tissue gets filled with blood. And as long as there's blood within those spongy tissues with valves kind of keeping it in there so it just doesn't leak back out into the veins, you maintain an erection. And so I only have one more part to this, and that's ejaculation. And then one more part after that, which is the cycles of hormones. And then this class will be pretty complete. I'm going a little longer than I expected, but I think I'll probably be finished by 8:15. And also, if you're here, really thank you for being here. I just appreciate people. I'll do my thanks at the end. I'll let that go for now. All right. So ejaculation. What is ejaculation? What is ejaculation? So there's two parts actually to ejaculation. The first one is called emission, like mission with an E in front of it. It always seems like a Tom Cruise thing. So we have emission and then ejaculation. So the first part before ejaculation, before the fluid starts moving out, these tissues, let's take this apart again, start to fill with fluid. So for instance, the seminal vesicles and the prostate, they start to get chunky. That's probably not the right word for it. They start to get filled with fluid. That's called emission. So the first part pre-ejaculation is emission. When fluid starts moving in. At this point, you're going to feel sexual excitement, or you're going to feel sexual excitement. So, but you haven't reached like ejaculation yet. So, but usually you're pretty close. Emission usually, it doesn't always, but generally precedes ejaculation. So then what happens is the next phase is here we go, the sympathetic nervous system, the one that's often called fight or flight. That is going to stimulate muscle contractions of these organs to push the fluids out through ejaculation. I'll say this again a little bit differently. So erection is a parasympathetic, is parasympathetically led by the rest and digest. Ejaculation is the sympathetic nervous system. So what I'm saying here is that if you have erection and ejaculate, two very different parts of your nervous system, parasympathetic and nervous system and sympathetic, are interacting together. So while I'm saying this, let me say something that is really important to know. They don't have to happen together. So the first one is very obvious. Multiple times, people with these body parts will have erection without ejaculation, right? For instance, morning wood, which is common, actually can happen throughout the night, but many folks will have erections during the night and not ejaculation. If they have ejaculation, it's called a wet dream, but generally erection without it. But also you can have ejaculation without erection. So a flaccid penis can also ejaculate. So it's just important to know. So while they can happen together, erection plus ejaculation, but they don't have to happen together because they're really different parts of the nervous system signaling these two different events. So again, so what happens during ejaculation is that the sympathetic, your fight or flight, is going to get really, is going to innervate the muscular tissue, these muscles that I'm talking about. They're connective tissue, really. The seminal vesicle, the vas deferens, and the prostate, they're going to contract and they're going to push the fluids from them into the urethra, and then the urethra is going to contract and it's going to come out, leave the body, and that is ejaculation. So ejaculation is sympathetic, erection, yes, and erection is parasympathetic. But if you've ever ejaculated, and so let's add orgasm before I go there. So, and then orgasm is the sensation, the positive sensation that happens with ejaculation. So for many people, they go together. Ejaculation and orgasm go together. I want to say one more thing. So then, I think that's it. So then that's pretty much it for ejaculation and erection. Oh, I'm sorry. If you've ever felt your heart racing and breathing deeper or shallower, but breathing faster while you're ejaculating and post-ejaculating, no need for cigarettes, that's because your sympathetic nervous system has just sent a bunch of signals to your body. So in other words, during ejaculation, your heart is racing, the blood's moving faster, you are in a fight or flight mode, which if you think about it, it's pretty obvious. So, there's tantric moves, there's ways to slow it down, which can be very positive, especially if you come too early, premature ejaculation. But basically, that's what ejaculation is. So I only have one more part to cover. I want to cover it now, and then I'll open this up for questions, So I want to talk about the hormonal cycles in bodies with these body parts in them. So once again, we're going to go to screen share and go to this. So what we have here is the hormonal cycle in male bodies. And I'm going to follow both of them. So the first thing to know is most hormonal cycles in animals are what are called negative feedback loops. Feedback loop means the idea is to keep things more level. So a positive feedback loop would be if more happens and more happens. So you make more of something, then more of something, then more of something, which could be problematic because there's no end in sight. Instead, I'll go through this. So I'm saying that these are negative feedback loops that are associated with the testicles and the brain. And that's what we're going to go with. So we're going to start with the Leydig cells, the ones on the bottom here. So as we've learned, the Leydig cells make testosterone. Testosterone is a classic, meaning old school, endocrine hormone. It goes into the bloodstream. And then any part of your body with testosterone receptors, and there are many parts of the body with testosterone receptors, might have an action depending on how much testosterone is released. So the Leydig cells, we're going to talk about Leydig cells making testosterone. Remember that the adrenal cortex, the adrenal gland, there's adrenal medulla, adrenal cortex. The cortex also makes testosterone, but right now we're just talking about the testosterone made in the testicles, in the Leydig cells, which lie between those seminiferous tubules. Hopefully some of these words will make sense for people here. So we're going to follow this diagram. So in this diagram, the Leydig cells are not making these minus signs. The Leydig cells are not making a lot of testosterone. So the hypothalamus, so let's talk about the hypothalamus. So the hypothalamus kind of go like this, and it's in there. The hypothalamus is the part of your brain that reads your blood. So you often hear that there's a blood-brain barrier, and there is, but your brain has to read your blood in order to make accommodations for hormones, for thyroid hormones, for fevers. I mean, your hypothalamus is the part of your brain that's constantly reading your blood and making changes to keep us in homeostasis, which means kind of your normal, right? Your normal body temperature, your normal thyroid, your growth hormone, all the other, many of the hormones are regulated by the hypothalamus. The hypothalamus reads the blood, and then it signals its second in command, which is the anterior pituitary, which is another hormonal organ, to release hormones to shift. So it's getting a little complicated, but I'll bring it back. So I'm talking about Leydig cells making testosterone. I'm talking about the hypothalamus reading the blood to see how much testosterone is in the blood. And then depending on how much testosterone is in the blood, it will signal or not signal its second in command, which is the anterior pituitary. So here we go. The Leydig cells are not making a lot of testosterone. Oh, so as I mentioned, so males don't go through any abrupt menopause-like thing. So if you want to call things andropause because of the changes in male bodies over time, that works, but it's very different than menopause, which is much more abrupt. And it's much more specific, maybe more than abrupt. Back to this. So the Leydig cells are not making a lot of testosterone, and the hypothalamus says not a lot of testosterone. And so the hypothalamus is not a lot of testosterone. Let's kick up the testosterone. So what it's going to do is signal to the anterior pituitary. It does this through another hormone called gonadotropin releasing hormone. Gonadotropin releasing hormone. This actually makes a lot of sense. Gonad is gonads, right? So we're talking about the testicles, which are gonads. And then releasing hormone, it's a hormone that gets released. So actually, gonadotropin releasing hormone makes a lot of sense. I will use the abbreviation, and it's just to make it a little easier, which is GnRH. So the Leydig cells are making not enough testosterone at the moment. The hypothalamus reads the blood and says not enough testosterone. And it's like, let's kick up the testosterone. So it tells the anterior pituitary via GnRH. So the hypothalamus kind of kicks the anterior pituitary with another hormone called GnRH, or gonadotropin releasing hormone. And then the anterior pituitary, in order to elevate the amount of testosterone in the Leydig cells, is going to release luteinizing hormone. So these hormones are found in all bodies, right? So male, female, it doesn't really matter. Trans, all different bodies have these basic luteinizing and follicle stimulating hormones. They're named because they were first discovered in female bodies. And so they were named for their function in a female body, in other words, luteinizing and follicle stimulating. But actually, what they do in other bodies is exactly the same thing. So we go through that. So I'm going to start from the top because I diverted as usual. The Leydig cells are not making a lot of testosterone. The hypothalamus says we need more testosterone. I'm not seeing enough. It throws out some GnRH to the anterior pituitary, and feeling that, the anterior pituitary releases more luteinizing hormone. Luteinizing hormone, there's receptors on the Leydig cells for luteinizing hormone. So as they receive more luteinizing hormone, they start to make more testosterone. As they make more testosterone, the hypothalamus says, oh, whoa, too much testosterone going on. Let's cool our jets. And so it's going to reduce the GnRH to the anterior pituitary. The anterior pituitary is going to reduce the amount of luteinizing hormone, LH, and the Leydig cells are then going to reduce the amount of testosterone. In a little while, the hypothalamus is going to say, whoa, we need more testosterone. It's going to increase GnRH, which is going to increase LH forever and ever and ever. That deserves a drink. That's number one. The second one is a little more complicated, and it's about the Sertoli cells. So the Sertoli cells don't make an endocrine hormone in this. Well, they do. They make one that has a very specific use. Let me say this differently. Testosterone has multiple uses in the body. The hormone that the Sertoli cells is pretty specific. So let me just jump into this. So if the Sertoli cells are not creating enough spermatogenesis, so spermatogenesis is the way that the Sertoli cells help the sperm mature from their immature until their spermy little tadpole bodies are mature. So again, the Sertoli cells nurture sperm through the process. If the Sertoli cells are not, have a kind of a slower spermatogenesis, a slower maturation, they release a hormone called inhibin. So this is a little different. Many people think that inhibin is read by the hypothalamus and I'm sorry, I'm pointing, doesn't help at all. So I want to say in this one, many people will think that inhibin, this hormone right here, is read by both hypothalamus and anterior pituitary, but I'm just going to keep it simple and say it's read by the anterior pituitary. So the Sertoli cells always release this hormone called inhibin. If the Sertoli cells are not very active in their spermatogenesis, helping mature sperm, it's read by the anterior pituitary as, wow, it's not making enough sperm fast enough. Let's help the Sertoli cells mature sperm faster. And what they're going to do is the anterior pituitary is going to release FSH, follicle stimulating hormone. And the Sertoli cells have receptors for follicle stimulating hormone. So as the Sertoli cells get more follicle stimulating hormone, I might have said the first part wrong, and then I'm going to have to repeat this in a different way. As the as the Sertoli cells start to make more sperm or mature sperm quicker, they release more inhibin. I might have got this wrong one step ago, so I'm correcting it now. So as they get more and more active, they release more and more inhibin. When the anterior pituitary is receiving a lot of inhibin, and inhibin is exactly what it sounds like, it inhibits. So as the anterior pituitary receives more inhibin, it's like, whoa, the Sertoli cells are too active. Let's reduce the activity of the Sertoli cells, and then they will reduce the amount of follicle stimulating hormone. So as the Sertoli cells have less follicle stimulating hormone, they slow down the amount of spermatogenesis. At one point, the anterior pituitary says, whoa, not enough inhibin. Again, sorry about the mistake in the beginning. And what they're going to do is they're going to increase the amount of follicle stimulating hormone. So it's basically, as the Sertoli cells are active, they release a lot of inhibin. Where there's a lot of inhibin, the anterior pituitary slows down the release of FSH, follicle stimulating hormone, over and over and over. So I don't know if I've said it, but people with these male body parts, they don't have monthly cycles. The cycles happen throughout the day at different amplitudes. So believe it or not, I think I'm finished. I can try to answer a few questions or people are interested. Now I want to say it, like, thank you very much for being here throughout this presentation. I hope you learned a lot. I hope this information is helpful. Next Tuesday from 6:30 to 8, I'm going to cover male health issues and herbal medicine. And I'm going to really focus a lot on the prostate. And then maybe I'll do another class afterwards, see what people are interested. And so I think it's next Tuesday. Today's Wednesday. I think it's next Tuesday. If you look at the schedule, it'll be correct. Once again, thanks to Michelle. I guess thanks to my parents for sperms and eggs. And again, I really hope this was helpful for everybody. This will probably be recorded. Well, this was recorded. Michelle will do her deft work and probably get this up on YouTube. And then I will send a link for this. But I really hope it was helpful for everybody. It's a lot of fun to teach. I adore these body parts, and I really adore teaching them to other people because I just feel like they're not well understood and not well taught. If you're still listening, somebody else who does this class really well is a guy named Sam Webster. And if you go to YouTube and type in Sam Webster, frankly, a lot of this I learned from him and other books, but Sam Webster has been the person who taught me how to use models. I mean, he didn't teach me directly, but watching him, I've learned how to use models much better. And also I just think he's a great teacher. So Sam Webster, he does pretty much every anatomical system in the body. It's kind of college level, but I don't know. I think I'm really a big Sam Webster fan. All right, let me see if there's any questions. And then let me see. I'm going all the way back. So actually, let me go forward. So Andy, all right. So Andy asks, what is the anatomical functional changes when it comes to pelvic floor dysfunction? So I'll talk, Andy, so I'm sorry to just keep saying, I'll say it next week, but I'll cover it. But basically, one thing that happens a lot with the pelvic floor is the muscles get weak. And when the muscles get weak, things can protrude. And if things protrude, then you have less control over the sphincters. In other words, like you can become incontinent. Also, it can affect erectile function. But like all muscles just get weaker. And then certain things make the pelvic floor weaker, especially pressure, like really heavy coughing, a very deep, when pressurized coughing, constipation, and pushing out feces also weakens the pelvic floor. But sometimes there's a lot of pain to the pelvic floor, and pelvic floor pain, and nobody knows why that happens. Or at least I don't know and haven't read it. I'll answer one or two more. Serena says that the testosterone is correlated with the sun. I've never heard that, Serena. I don't know if it's true or not true. It's definitely not something that gets discussed, but that doesn't make it true nor not true. I've never actually heard of any outside factor like moon or sun affecting testosterone levels. But if it did, it wouldn't surprise me too much because these spheres that are close to us can definitely alter us. So Alex asked what behavioral emotional. So Alex, it's a really complicated question. What behavioral emotional physiological effects did testosterone inhibit? So testosterone, here's what I'd like to say. I think the best book I've ever written, I wish I wrote a book. The best book I know about the effects of testosterone is by Robert Sapolsky, who I think he's a great author. He wrote a book called, Zebras? Why Zebras Don't Get Ulcers. That's not the book for this, but Why Zebras Don't Get Ulcers is a great book. But Sapolsky also wrote a book, The Troubles with Testosterone, and he wrote a newer book about hormones. And I would suggest those books to learn more about the physiological effects of testosterone. But to put the answer differently, it's not really so clear what they are. Some of the effects are pretty obvious in some people, but I'm going to say that it's a very complicated question, and frankly, I'm still learning what the effects are as well. Whoops. Let me see if there's one or two more questions. But that one. So Michael asked, what about talking about the repeated hot or cold water exposures affecting parts of the reproductive system? So there were some experiments. So as I've talked about, sperm formation happens, or sperm maturation happens at a certain body temperature. And so there was the idea of hot tub sex, right? So the idea of having heterosexual intercourse in very hot water potentially would kill the sperm? The answer is it definitely does not, because the sperm are in the mature sperm in the vas deferens, and they weren't affected. As far as like, I don't really know its other effects. I don't have a good answer to like, does like going from hot to cold water like increased blood supply, which it might, to organs or something else, into the lower reproductive organs? Some people feel like it's helpful, but I don't really have enough science behind me, or really just clinical experience to answer that. It feels like this is the time for me to say I don't know anything to any of these questions and keep putting share on, except instead of chat. So Marcy asked about the functions of foreskin. A guy wrote to me today. I don't know if his name was Will, and he wrote me this letter. Actually, I don't know what the male or female. Somebody wrote me a letter about the functions of foreskin, and it was all the stuff I've never heard of. It looked amazing, and he sent me some links. But in general, the foreskin protects the tip of the penis and increases sexual sensitivity, and also lubricates it. And so there's a bunch of stuff that's called schmegma, but the foreskin basically, covers the tip of the penis, and it helps protect it, and then it also lubricates the tip of the penis. But those are the main functions. But I'm telling you, I just read a little bit from this thing, and there's a whole bunch of ideas that I had never heard about foreskin. As might sound for me, I believe keeping foreskin on is an excellent idea. I didn't go into it. I was raised a Jew. I was also raised in the 50s, so circumcision, or as a Jew, bris, was very common. But I would assume that leaving body parts on is a good idea, unless there's dysfunctional in some way. So I think that's it for that. All right, I'm gonna let Michelle go now, and I'm sorry I'm not going to answer any more questions. Once again, thanks so much for being here, and I will probably send you the links for all this. Thank you, Michelle, and thank you, everybody.